Good morning, everybody. We're going to talk about a not common topic. Maybe some of you have already heard about this physiopathological link. We all know that it exists. We haven't addressed it so much, but fortunately, in recently we are having more understanding of this link, and we are exploring this topic more into depth. This physiopathology between the heart and the brain, to the point that there's a new specialization which is called neurocardiology. This is a very interesting and new area of study, and we have heard phrases like my heart is breaking because of something emotional, right? And this has dated back to times that we don't even know anymore. We do know that emotional trauma lead to a physical impact that is quite relevant. We do know not just about the link with cardiac failure, sudden death of cardiac origin, but also with other type of degenerative diseases or inflammatory diseases, and even neoplasies. We know about the link of depression with a series of chronic diseases. So what we are going to do is to try to review some of the things that we start to learn about this link, and to try to correlate the new aspects with what we already know. There is an interrelationship that is physiological, or I would say anatomic and physiological, between the heart and the brain. We say that the heart has its own brain. What is the definition of a heart? Well, it's a compact set or numerous set of neurons that have connection amongst them, and that have inflows and outflows, and have a series of mutual influences. So this could be the definition of brain, and if it is so, then the heart has a brain. It has nervous glands, intrinsic and abundant. This is a slice of a nervous gland of the heart, and they are located in an abundant way, especially surrounding the emergency areas of the vessels and the auricular areas. And these nervous tissues are very compact. They're numerous in terms of the neurological load of neurons, and there's a direct link from the anatomical and physiological perspective with the heart. We know that there is a dynamic communication that is two ways between the heart and the brain, that mutually and continuously influences the functions of both organs. This communication is established in different ways. A neurological communication, these are nervous impulses; a biochemical communication through neurons, neurotransmitters, and a biophysical communication, for example, depression, bioreflex, and we have the respiratory and cardiac rhythm that is mutually in communication. And there is an energetic communication through electromagnetic fields that truly exist and can be referred to. We know that there is an influence of attitudes and negative emotions, and positive ones, on the cardiac rhythm. This has been well established and well studied. These negative attitudes, this means the depressive thoughts, negative emotions, fear, sadness, have a pretty much chaotic cardiac rhythm. They lead to a loss in the harmony of the cardiac rhythm. So these positive aspects like attitude, love, compassion, compression, happiness, they actually lead to a variation of the cardiac rhythm that is much more harmonic, that it's much more predictable, and that goes in a cyclical way and truly in harmony in relation to these positive thinking attitudes. We also know that the variations in the cardiac frequency are related with the health of the heart and the mental health. This cardiac frequency is not constant. There's a variation that is physiological, as we said. We have the recovery of the cardiac frequency in the post-stress. As you may know, this is a predictor of energy as well, and this is related also to coronary diseases. So as you can see, there is an entire series of interconnections between the harmony of the thoughts and the harmony of the cardiac effort. And this is established through well-known paths. There is a relationship between the impulses of the internal and external cortex and the impulses that come from outside and those that we generate from within that affect the cardiac rhythm and even the flow of ions within the situs that could lead to serious arrhythmias and complicated arrhythmias. And this is transferred through other empathic and presympathetic systems, and normally the positive emotional aspects are more developed in the left hemisphere, and this causes a parasympathetic discharge on the parasympathical side, and this tends to be disseminated through the sympathetic system, and there's an opposite sign effect on cardiovascular pressure. And these emotions, when they're intense, can actually lead to an imbalance between the sympathetic and parasympathetic balance, and through a modification of the charge of ions through the membrane can lead to severe arrhythmias. Fury and madness and anger are related with the parasympathetic aspect, while the other positive emotions are related oppositely. So the parasympathetic could be increased absolutely or relatively through the reduction of the vagal tone. In any way, there is a relative activity of the parasympathetic activity. However, these arrhythmias are more often through an anger episode. This is the classical episode of anger crisis that can lead to ventricular arrhythmias or cardiac arrest and sudden death. Of course, they are also related to other types of emotions. Maybe you have heard about the fight or flight phenomenon. Many times when we are facing a threat, we are wondering what to do. Should we face the threat or should we run away from the threat? If we face it, we fight against it, or should we escape? But in both cases, we need our maximum capacity of thinking and of being able to exert a physical activity, either to fight physically against it or to run away from it. This is something very primitive, right? This is extremely primitive, and fortunately, today, the situations in which we have a real physical threat is quite rare, so that for us to be in this situation. But in modern times, this has been transferred to other situations. For example, the threat because of personal issues in our household lives, or it could be at our work, or it could be in our daily lives. While we drive in traffic, we become very tense. We feel threatened by the car in front of us, next to us, behind us, and we have fears because there's a lot of crime, and sometimes we are afraid that we can be facing a situation like that. So this direct threat has been transferred to other situations, but the result is exactly the same. there is a predominance that is relative of the sympathetic discharge, of the energetic discharge, and this leads to the situation that we know of as stress. The issue with stress can be handled, but we can only handle it up to a certain point. And what we can achieve if the situation is very intense or it remains in time, this threat situation, what we can do with it is that we can reach the static balance, which is an adaptation of our organism and our mind to bring the balance to a superior level of chronic stress so that it's adapted to chronic stress. So it would seem that we would be in a totally normal and relaxed state, but we are truly in a chronic stress level, and this is the level that we coexist with every day. And we have reached an active coexistence with this level, but this energetic discharge is acting in a constant way. So what happens in the brain is that this external situation comes in through the prefrontal cortex, and this prefrontal cortex is designed to filter these emotions or these threats, and it gives it a rational context. From the frontal cortex, this is the most evolved section of the nervous system of human beings. However, this prefrontal cortex that is supposed to be modulating the input that comes from outside that is threatening us affects the hippocampus area intensely. And this modulation or this modeling is seen in this stage of our evolution. It's actually weak still. And the hippocampus, which is a more primitive structure of our brain, receives this external stimulus that is threatening with a relatively low level of protection given from the prefrontal cortex. However, it's much stronger because it has been in activity for a much longer time, this activity between the hippocampus, which actually transforms the neurocardiological system completely, because this external situation, since we have a low filtering level, it becomes into a real threat, and it prepares us for action, to be in fight or to escape. I am saying this because you will see that it's important to see the location, the anatomic location and the physiological links between these parts of the brain and the heart. So having said this, we can go to specific clinical situations in which in practice it seems to show what we just mentioned right now. For example, we have a clinical model, the Katsubo model. It's an interesting model to be able to learn more about this relationship. You know that this is seen mostly in women with menopause, and then we have a cyclical or intense system. This is an acute changes in the cardiogram with acute coronary syndromes, and there is a relationship with the left ventricle with a dyskinesia of the apex. We can see that this is a reversible case. So this is all the background information collected from our patients. We could have a series of situations that lead to intense physical stress situation or physical situations like surgeries, accidents, and so on. This is a typical image of the ventriculogram in the atrial image, and coronaries that are completely normal without any known obstructions. The angiotach has also given us the possibility of looking at this patient because we see the ventricle and the cardiac remodulation that is transient without any lesions. And how do we explain this? The hypothesis that is most widely accepted so far is that facing the situation of physical or psychic stress, there is an energetic discharge that stimulates the receptors in the heart, especially the ones here, beta 1 and beta 2. But these beta 2, you can see that they are the ones that a negative inotropism, and normally they are mostly concentrated in the region of the apex, which is actually where we have the situation. And the beta 1s are mostly found in the basal region of the heart. So this could explain the basal hypercontractibility with the hypercontractibility or a dyskinesia of the anterior region. And interestingly enough, there are Takotsubo syndromes where we can see this happening in other walls. It could happen in the inferior wall, in the lateral wall, in the anterior proximal wall, and that would be apparently related to different factors in the concentration of beta 1 and beta 2. There's also a theory that says that there could be kinkings. This is mostly common in women with menopause through an energetic crisis. The kinkings could actually strangulate the artery and the flow, in addition to the systole, and the effects that are consequent would lead to this situation. So this would be a more mechanical explanation, but it could be somehow related. Here we have a case, which is a courtesy of Dr. Pace. Unfortunately, she wasn't able to be with us today. This is a medicine study. It's in the acute phase of the Takotsubo, and in the later stage, we can see that there is a reduction of the flow. However, there are cases that have been proven and say that the flow is relatively preserved. But truth is that time has gone by and there's a spontaneous and complete recovery. Here we have a phase analysis in the acute and later stage. You can see the synchrony that spontaneously recovers afterwards. Also, the MIEBG that is used here to study the connection with the heart and the Takotsubo, we can see how this patient has an ejection fraction in acute stage and the relation of the heart with the mediastin of 162, mediastinum of 162, and in the recovery phase, a couple of days later, the relationship of uptake of the heart improves with the diastole and the rate becomes normal again. Also here with MIEBG, we can see how in the acute phase it happens very rapidly, and a couple of months later it becomes normal. This is aspect with MIEBG. In Takotsubo, in the acute phase it's committed, and once again in the recovery phase, we can see a complete restoration of the use of the glucose. And here we can see a mismatch, an inverse mismatch, which happens inversely from when we analyze viability, right? So in this case, there is a perfusion that is relatively preserved with an alteration of the glucose metabolism. This is a summary of what we have found. This perfusion, in this case, it's mildly altered or somewhat altered. We have an alteration of the IBDG. With marked amino acids, we found something similar. Unfortunately, this is a marker that is not widely available, but this is a very interesting model to explore the relationship between, because there are truly anatomic changes that are spontaneously revertible, and they are only caused by an overload of catecholamines. So what happens in others? We have other, for example, in other cases, we also know that it's also related with late disorders that are sometimes severe. More than half or most patients that have anomalies or infections, arrhythmias, or systemic dysfunctions or cardiac transient remodeling, more than half of them and up to 95% of patients with hemorrhage present these alterations. We can think that this is a similar mechanism to Tatsumoto in this case, which is caused by endocardial hypertension that is sudden of the hemorrhage, and it could stimulate the chronopronoptic center, which is located in the posterior area of the left insular. We can see that this leads to the QT, and it affects these areas of the brain and the idioventricular rhythm and up to asystolemia. There is an EKG that is quite typical in this type of hemorrhage. There are also changes in the uptake of MIBG. This is a publication that is presenting these phenomena in a very didactic way. And we have this curve as well, the Osborne curve, which is very characteristic with this curve and the peak of the R wave. I want to thank Dr. Araujo, who provided us with material on this topic. Is Raul here? Thank you, Raul. Very well. So continuing with the correlation between the heart and the brain, we also have two interesting models, which are the Parkinson's disease and neurodegenerative diseases that also have an impact at cardiological level. Parkinson's, as you may know, is a neurodegenerative destruction and disease. It's classified as a disorder in movement because it leads to shaking, and the disease also leads to alterations in the cognitive functions, in the expression of the emotions, and in the autonomous function. Fortunately, we have markers, as we said, to explore the cardiac innervation and also to explore the receptors. For example, if we have dopaminergic markers for SPEC, the normal image shows us clearly that the head is here in the transversal slices, and we see that the patient normal is this image here, and in a patient with Parkinson's, the degeneration of these basal nuclei actually are affected. So what happens here? There's also an alteration. You can see this is a normal patient. These are markers that show a normal function, and also cardiac innervation markers that are normal, MIBG. So what happens in Parkinson? You can see that there's a lack of uptake in the heart. That means that cardiac innervation completely. It's interesting enough that MIBG, cardiac MIBG, is being used in some cases for diagnosis of Parkinson's disease. When there are concerns or confusions or doubts, you might know that there are very many diseases that could be similar. If we suspect Parkinson's disease with a cardiac denervation, the positive predictive value for Parkinson's is very high. So what happens with the Alzheimer's disease. You know that it's a cerebral amyloidosis. It's a protein which is beta amyloid. It's a protein different from the one that causes cardiac amyloidosis, but we can also have deposits of beta amyloid in the heart, and there are patients that can show this double deposit. As you can see, interestingly enough, there are also common risk factors between vascular risk and the load of beta amyloids and the declination of the cognitive activity in patients who are elderly that are clinically normal. I don't know what is the definition of the elderly. It's quite a mystery, actually. So we have seen that there is a gene as well, a APOE gene, that with two variants, I2, I3, and I4. We all inherit two variants, one from each parent. And 50% of the population has two copies of gene E3, which is the most common form that is not related to cardiovascular risks or Alzheimer's disease. But to have at least one copy of variant E4 increases the level of LED and triglycerides, as well as the risk of triglyceridosis and coronary disease, and it duplicates the risk of Alzheimer's disease. So this relationship between the risk of Alzheimer's and the risk of cardiovascular disease is quite interesting. Those with two copies of E4 have 4 times the risk of suffering Alzheimer's disease, and this happens to 2% of the population, and up to 60% of patients with Alzheimer's do not have this E4 variant, which means that it's not a condition as such, but it's a statistical correlation. As Dr. Soman explained, we now have a series of methods to explore cardiac amyloidosis, and we also have a series of methods to explore cerebral amyloidosis. The question is, in the future, we might have a solution to define the types of amyloids with one single PET study, maybe, or with more than one PET tracer. So having said this, we just briefly explored the cardiopathy models, either energetic or catecolaminergic, and the ones related to the heart. And we could see if there's a possibility of establishing a new paradigm that explains or that helps us establish the cardiovascular risk through the measurement of stress. These could be neurological diseases, for example. In nuclear cardiology, this relation between stress and cardiovascular pathologies, this is not something new. In some situations, we still use mental stress, because yesterday when we were talking about this, we didn't actually mention it, but mental stress is a very efficient test to discover these sectoral relations of perfusion. So this is nothing new, but we haven't studied its correlation that much either, because it's very hard to measure. A person could be going through mental stress with mathematical calculations, but for one person it could be very stressful and not so much for others. So to adapt the mental stress test with the characteristics or the person as such, this is something hard to do, hard to standardize.
But see here how with perfusion studies to measure absolute flow with oxygen 15, with mental stress you can see a global reduction in flow in regard to the basal test. And what we know now is that there is a bond that goes through different organs and systems. This was unsuspected a short time ago. There's a bond with the with the spinal nerve. The stress stimulates the spinal cord in interactions, elements that interact with inflammatory processes, with inflammatory cells that are going to act on the atheromatous plaques. And I would like to close with this. This is a study that came out in February 2017. It's by Harvard University. Dr. Tawakol, we met him personally. He was introduced by Dr. Joao Vitola. We had a very interesting talk about the study he published, which is absolutely fantastic. If this is confirmed, then it could be a revolution, a very interesting revolution in the sense of what stress is, of stress as a cardiovascular risk. And the area of the amygdala is where the main interaction occurs between external stimuli and the trigger of the fight or flight reflex. This causes the stimulus of the spinal cord to liberate monocytes, pre-inflammatory monocytes, which produce cytosines. This causes an inflammation of the atherosclerotic plaques. There are cardiac events, and there could be an increase in PCR. Emotional stress, measured by rest activity in the amygdala, it predicts a cardiovascular event in 293 patients. You can see here there's a patient with no cardiovascular event. You can see the amygdala activity. It's more diminished, it's lower, and it's more intense here in patients with a patient who had a cardiovascular event. You can see how the visualization of the amygdala activity, the activity in the walls of the big vessels and the spinal cord, you can see the activity here. We can characterize the presence of emotional stress. And we can see the functional impact of emotional stress. Therefore, when we go to the risk factors, to the CV risk factors, we have a kind of table like this. Personal history, smoking, diabetes, hyperlipidemia, sedentarism, cholesterol, triglycerides, etc. But stress does not appear often. Why not? Because we ask, are you stressed? Yes or no? We can't measure stress. We measure everything else. There's a lab value for everything. There is a weight value. There's a blood pressure value. But stress doesn't have any unit to be measured. But what if these images become more widely available and we're able to see the amygdala activity of a patient, and in one single study we can see the activity of the bone marrow, the activity in the atheroma plaques. So as long as this is available and this correlation is confirmed between stress processes and general inflammatory activity, and namely in the cardiovascular system, it would be a tremendous tool to characterize patients in risk of cardiac events. This book by Dr. Valentin Fuster is very much recommended. It says the heart gives you an amount of life, the brain gives you quality of life. So keep calm, zero stress,